Dear attendees, Mr. Chairman, welcome to the first NAVAt meeting, International Symposium on Automated Low-Flow Anesthesia and Visual Drug Display Systems. Obviously, this meeting would not have been possible without our sponsors. We welcome and thank the sponsors for helping to organize this event. Now, what is this all about, this meeting? About 150 years ago, we were giving anesthesia by pouring ether onto a mask. Obviously, it was hard to figure out what the delivered concentration of the inhaled anesthetic was. Then technology evolved and vaporizers became available. And because of the vaporizers being available, we knew what the delivered concentration was. Now, providing we were also using a high fresh gas flow, we also knew what the patient, here, that's the lung of the patient, was actually inspiring. And the reason for the high fresh gas flow was, one, that there would be no rebreathing, and two, there were some stories that the vaporizers were only accurate if high fresh gas flows were used. Next became available gas analyzers. So from that point on, we were able to actually measure the inspired and the end-tidal gas concentrations and carrier gas concentrations. Obviously, that allowed us to use a circle breathing system. We now knew the vaporizer dial setting, but also the inspired and, more important, the end-tidal concentration over inhaled gases and anesthetics. And we now have good anesthesia machines that actually allow us to work with this technology. We have here the Leon Plus, for example. We have FlowY. These later on, in between the sessions, if you have a few minutes, please go attend the separate rooms to the right, where you get a sneak preview of the new Caelus by Hendrickx and the FlowY machine. Some of you have gotten an invitation to attend. Please do visit the Hendrickx site. So we had the vaporizers, we had the gas analyzers, add to this computing power and modeling, and you get a predictive display. Based on the settings of the vaporizer and the fresh gas flows, the computer is able to predict what would happen, what the end-tidal concentration would be if we do this or that with the vaporizer dial setting or the fresh gas flow. So the anesthesiologist is still controlling the settings, and the Perseus, for example, has a predictive display. Add to this feedback theory, fuzzy logic, and you get automated low-flow anesthesia. So technology, again, has evolved. We have the ACES end-tidal control, the Zeus end-tidal control, the FlowY that will become end-tidal controlled, and something's cooking at Heinen and Löwenstein as well. So the machines will actually control the carrier gas and agent administration to get to the desired end-tidal concentration. Now, if we work with end-tidal control, we have to set the end-tidal concentration. And you choose a certain end-tidal concentration to attain hypnosis, immobility, control of the heart rate and the blood pressure, and other clinical endpoints. We can use a propofol instead of inhaled anesthetics, and we often add opioids. Extensive research and computing power now allows us to estimate opioid and propofol concentrations after you have given a certain amount of the drug. We can actually estimate the concentration of the opioid. We can estimate the propofol concentration. Obviously, we measure the end-tidal, and we use a combination of these drugs to attain these clinical goals. And we can do this with different concentrations of both drugs, which we combine. And this line here represents all the possible combinations of this agent and this agent to get 90% of the patients unaware or 90% of the patients immobile. These lines are called isobol. Now guess what? This is a PK/PD visual drug display system. So technology and research have evolved at a rapid pace, and it is a bit of a challenge to keep up as a clinician with what's out there. But I'm convinced that, I mean, this is the smart pilot, this is the navigator, that while technology has always been the limiting factor in getting us the tools we work with, now it may be the other way around. I mean, we as clinicians may tend to lag behind with all the technology that's out there. So I hope this meeting will actually help bring these three things together: technology, research, and the relevance for clinical practice. So here we come to the name of the meeting. The smart pilot and the navigator are guides that navigate your anesthetic to a certain target. There are others that are looming around the corner. For example, the QCOM was presented at the last ESA meeting. It will never replace the anesthesiologist because there is always biological variability. So I want to end my introduction. If we want to evolve as a specialty, we have to expand our scope beyond the operative phase. But likewise, we should not forsake to optimize how we apply pharmacology to our patients by the tools that are available. Investing in research is often claimed to be critical for the existence of our profession. Failing to apply the research of our colleagues for the benefit of our patients and our clinical practice is not an option at all. Let research and technology not pass you by. Today, let's explore together what it has to offer to you. Learn, enjoy, participate, and be critical. And remember, there is no progress unless we continue to discuss different points of view. I am particularly happy that this meeting is endorsed by the European Society of Anesthesiology. And Professor Stefan de Hert, who is chair of the scientific committee, will be sharing the first section this morning. In the afternoon, Dr. Luc Faubert, who is chair of the Belgian Society of Anesthesiology, will chair the afternoon session. Thank you very much.